Is Dr. Irene Tracy coming to us from the University of Oxford, who will be talking about the neural correlates of pain perception. Very relevant topic.
Thank you. Let's get loaded up here. Well, thank you very much to the organisers for the invitation. I'll just get this loaded. I actually thought I had a little longer, so either I'm going to speak faster than I normally speak, which is pretty quick, or we just won't get through the whole talk. But what I wanted to do before I actually start was just to move to a study which has got nothing to do with pain, but is relevant to some of the things that have been raised this morning, and that is just the use of neuroscience information and how one can use it in courts of law, and we've heard it referred to this morning as a potential way of manipulating the jury or manipulating the layperson, because people are really persuaded by neuroscience information. So this was a study, some of you might know about it, where information that had a good explanation or a bad explanation was coupled with and without a completely nonsensical neuroscience piece of data or information. So the student group and the novice group, who were not neuroscientists, were totally persuaded in the bad explanation to have a higher satisfaction in terms of the explanation, even though it was really horrible, when it was coupled with a piece of neuroscience information that bore no resemblance at all to what they were talking about, whereas obviously the expert group were not persuaded whatsoever. So I just throw that out there for a bit of discussion, because I think it's a really important study for, again, potential abuse in courts of law by the bad lawyers out there who might want to manipulate the jury, or people knowing that this can be very powerful information when coupled and people can use it differently. So I just threw that out there because I think it's quite relevant for a lot of what we're discussing. I work on pain. Some definitions are probably quite useful because I think, again, this is an area, as Hank mentioned earlier, it's a high-ticket item, huge medical health problem, potential relevance for extrapolation in courts of law. And people tend to think of pain in this very binary way, that it's this single thing that exists. And the one thing I want to persuade you of by showing you some data is that pain is a very, very variable thing, and therefore you can't just think of it in this binary, simple sense that yes, no, you're in pain, because it depends what pain you mean. We do have definitions. The sort of governing body of pain, which is a body that I'm involved with, the International Association of the Study of Pain, have these two definitions to try and encapsulate what we mean by nociception, that is tissue damaging, so that's just simply the detection of tissue damage by specialised receptors in your peripheral nerves connected to two main fibre types. Pain, however, is the subjective response of the individual to the nociceptive input to the brain and may be totally unrelated to the actual physical parameters of intensity and duration of the stimulus. The more broad definition is that it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. You don't need to have tissue damage to experience pain, or described in terms of such damage. That is the formal definition of what we mean by pain. And pain is not something that exists out there. Neither does pleasure, neither does warmth. These are not physical entities that are out there. They are perceptions that you generate. They are emergent experiences. And they vary. You know, if I took any of you now and burnt you, trial by trial, it will vary. If I just talk to you in between one, just a subtle change in the way your brain is oscillating. So pain isn't this physical entity, it is an emergent experience that is highly, highly malleable. And why is that? That's because nociception, that tissue damaging thing, generally, all things being equal, will lead in a nice linear way to the pain you feel. If I burn you more, it will hurt more, and you'll say ouch, and you'll have more active brain. But I can do all sorts of manipulations to that nociceptive input and what your brain state is doing, and totally uncouple those two inputs and make it a very non-linear relationship. And that generally is the case, particularly as we transit from the more simple case of acute pain to chronic pain, which is a whole other ballgame. And what we've been working on in the sort of pain imaging field over the past 15 years are all the different factors that contribute to generating that non-linearity between the nociceptive input and the subjective experience that is pain that the patient will come and report to you, either in your physical consult room or in a court of law. And they're crudely listed here. We have events. If I had a laser pointer, I would point them out. Maybe this is it here. There we go, yeah. So we have physiological events that we think of as peripheral and central sensitization, thank you very much, which lead to sort of plastic, if you like, hard wiring mechanisms in the spinal cord and the brain that in effect turn it on permanently. That's what happens when that unfortunate 1 in 5 become the chronic pain patient, and they make that transition from good, healthy, acute pain that's telling you something's wrong with you, you must look after yourself, you've hurt yourself, give it normal tissue healing time. For most of us, that is a great thing. We nurse ourselves, we get better, and the pain goes away. 1 in 5, they don't make that reversal, and they make transition to a permanent pain state, largely because of these phenomena here, because of a genetic susceptibility, basically, to that. Coupled to that, you've got all these brain processes that really play havoc with what's going to happen to those nociceptive inputs and how they're going to be processed. That controls how much pain the subject's going to report to you. So the context of the situation, expectation, beliefs, the cognitive sets. Are you too hypervigilant, too much of a worrier, a catastrophizer we call it? Are you very anxious? Are you depressed? All these things are brain-driven processes. They will alter the way the nociceptive input is processed. That will change the processing in the brain. That changes the pain experience. So what we're trying to do is sort of unravel all that and come up with a simple signature. Well, you can't, because, again, it depends on what the quality of the pain is. So in terms of the enormity of the problem, again, 1 in 5, 20% of the adult population are defined as having a chronic pain disorder. The cost in terms of management, treatment, days lost to work because people wake up with a migraine or backache and they don't go to work is a staggering 200 billion euros per annum in Europe and $150 billion in the USA per annum. We have all these different neuroimaging methods available to us to actually look inside the central nervous system and make that objective measure related to what the person describes subjectively, and together in a more multimodal way we are coupling them all together, giving us this unique sort of functional, structural and chemical window on what's going wrong in that transition to chronic pain. And for many cases, and I know that obviously the focus here is for the people who are faking it or on disability fraud, but for obviously the majority of cases in the clinical scenario, it's not report bias. And what largely I think imaging has been fantastic at doing in the past 10 years are taking those very difficult chronic pain patients, particularly those with what we call functional pain disorders like fibromyalgia, irritable bowel syndrome, and show actually there is something wrong with them. When you actually look inside their central nervous system, it's really wrecked. And therefore it's not report bias. It's not just this person is whinging and they're a neurotic, depressed 50-year-old housewife and she's now complaining of atypical facial pain. If you actually have these measures, you can go beyond the subjective report and all the biases that are out there, often in some of the medical areas, you see that there is something wrong, and that's been a very powerful use of imaging, and I think probably its greatest contribution in the pain field. But certainly in the UK anyway, I don't know if it's true in the USA, because it's so easy and you never can know somebody's pain, it's sort of a tenet of law as I understand it, it is unfortunately the one thing that is used most commonly for disability and welfare fraud, because you can never know somebody's pain. Or can you? So that's what I'll talk about now. So again, simple study, take you all, burn you on your leg, be 50 degrees, 5 seconds. As you would expect, not all of you would report that as the same pain. We all have different pain thresholds. We all report pain to a different level. Are we all just squealers and whingers? Some of us who are saying it really hurts, and some of you are real tough macho because I'm a female and you're trying to just be cool and say it doesn't hurt so much. What you say, is it really what's happening in your central nervous system? So this was a study that Bob Coghill did, very simple, did exactly that. You got your squealers. If they say it hurts, they really do activate more brain. The group that say it doesn't hurt so much, they really don't activate more brain, again, in areas that we know are involved in processing the experience of pain. Why is that? Combination nature-nurture. Sure enough, a lot of it will be genetics. Right from the get-go at the transduction point of those nociceptors, this group will probably send in an increased input to the brain. But it won't all be that. Fundamentally, how you've evolved, your cultural influences, sort of nurture interacting with genetics will change, as I'm sure we'll hear about in the development session a bit later, how you're wired up and how you're going to react to what is, in all intents and purposes, the same nociceptive input, the same tissue-damaging event will be reported differently. We've gone on and shown that even, it gets more complicated than that, even just how you are right now, before I even zap you, potentially with my laser, how your brain is wobbling and coupling and talking to different regions will predict whether you report that as painful or not. And without, again, going into the anatomy, because I haven't got time, but basically key areas that we know are very important for driving the endogenous opioid system, centred on the very old part of the brain, the brainstem. If you are cycling and talking to that, and then I burn you, you don't say it's as painful because you've basically boosted this natural endogenous inhibitory system, so you get the benefit of it not hurting. If you don't talk to that and you drive an area called the anterior insula, you'll find it more painful. And again, trial by trial, we can just oscillate that. But what's really interesting is the actual strength of that coupling. We heard a little bit this morning about how your brain is wired up. If your brain is a bit loosey-goosey and not so good and not so wired up and you're not very good at coupling to these structures, that coupling strength between these key areas correlates very significantly with core factors about you. Trait anxiety. This is subclinical levels. These are healthy students in Oxford, but just some people are a little bit more anxious, aren't they? Some of you a little bit more neurotic than others. And if you're just a little bit on that edge of things, you're just wired up really loosely. And that will dictate whether, when I zap you, depending on how brain is coupling, whether you're going to find that painful or not. I would posit that is a predictive indicator of that 1 in 5 who, if they sustained an injury or some sort of process, would become the chronic pain patient. So again, this issue about sort of, I guess, the sort of complexity of it, that you know, The report's very difficult. What's going on behind the scenes, which is what we're seeing here, is a lot more complicated. And so I really, really push this view that we can't think of pain just in a simple binary way. It's a very complicated experience, and therefore there's not going to be a unique signature. But there are many signatures, and so basically what we have is this plethora of brain regions that very commonly will activate in response to any acute pain experience that you might have. But what is really, really intriguing about it is that the core set of them, which you see commonly referred to as the pain neuromatrix, that's an expression I actually hate, but basically there is a hard core that encapsulates several structures of the brain that will give you the sense of where the pain's coming from, what type of pain it is. You're taking your attention to it. I've been burnt on my left hand. It's a burn, not a pinprick. You attend to that, and you have a sort of visceral, unpleasant, affective reaction to it. Those are captured in these sort of core areas here. But for those of us who are from the neuroscience area, we know there's nothing special about them. They all do many other functions inside the brain. So why is it that when they come together and activate, you have this acute pain experience referred somatotopically? In addition to them, you can activate all these other structures, amygdala, hippocampus, and you will, depending on right here, right now, the context in which I'm giving you your pain event, and whether you're a little bit more anxious, a little bit more depressed, or whether I change that, or whether I distract you, or whether I manipulate your expectation. You will bring or you will not bring those different structures to the activation map. And that's why I refer to, if we want a readout on the N of 1 to say if somebody's in pain, it's a lot more complicated. You've got basically a unique fingerprint or signature for that individual that will tell me, as a sort of expert in this field, what it is about their pain. Is it predominantly still coming in from the periphery, or has the surgery fixed that arthritic knee or hip, or has the drug helped, or have they just got better, but they're still saying they're in pain? This, by looking at this, I can tell you whether they're in pain because they're actually switching on centrally those structures, or whether there's a trickle coming in and it's been massively amplified, and that's what's contributing to that experience there. Now, within that set, there's been this holy grail that where within that would you target? Surgically, where would you use as your sort of readout for truly the person who maybe is faking it? There isn't anything coming in for the periphery. So is there a sort of N1, if you like, a nociceptive cortex for the pathways that bring in the information from the periphery? People have done a lot of different work looking at that, and I'll show you where we think that is focused. The idea that there is an equivalent P1 for pain, like we have V1 for vision, S1 for touch, auditory cortex, is just nonsense. It's just the wrong way to think about pain. There is not a P1 for pain. Pain emerges thereafter. Having hit the nociceptive cortex, it passes out trial by trial, experience by experience, because pain has to be malleable because of the nature of the beast. So there is no P1 for pain. It, again, will access, as you can see, in a variable way, a very complicated and broad and bilateral set of brain regions. But the N1, if I was going to put the N1, the way that we've been looking at it and others, which is illustrated here, is to do what we call a somatotopy study, so to see, you know when you're burnt on the hand as opposed to the foot, as opposed to the face. So there has to be a labelled line, a wiring up, if you like, between those nociceptors and where it hits the brain, so you know in a sensory discriminatory way where that pain is. So our group and many other groups have done a lot of work doing somatotopic studies where we give painful stimuli in different body regions, different types of pain, so again it's a cross-modality and a cross-body region, and we keep converging to this area called the posterior insula and the secondary somatosensory cortex. This seems to be where the N1 for pain is. Interestingly, it is the only cortical area that if you stimulate, you will generate an experience of pain. The only cortical area where surgically, when they've done it for epilepsy and they sort of went and had a little poke there, that you will generate an experience of pain. That is not P1, that is N1. It then communicates to the anterior insula and passes it all on. That's when pain emerges. But as a potential readout for a true peripheral input for pain fibres being activated, that would be what I would mortgage my house on. And again, I'll skip over for time. If you do a brain reading approach, thankfully it's been introduced in the previous talk, so I don't have to go into the whole multivariate pattern analysis, but we've got some data just hot off the press this week from a study where we've done, again, trial by trial, hovering on that pain threshold, so 50% are painful, 50% are not. You train up the classifier, you do an analysis, and you look at what brain regions predict whether it was a yes over the threshold trial versus no, it was not. And what was very satisfying, if we just look at this when the actual pain stimulus was on, is right up there we've got these S2 structures coming up, in addition to our favourite anterior insula, and again areas of the anterior cingulate cortex and the ventrolateral prefrontal cortex. So again, the brain reading would keep converging, that again somatotopically from those previous studies and with these sort of brain reading approaches, that we're starting to hone in on what seems to be the network that might indicate truly a peripheral input as opposed to just anticipating pain, where S2 bombs down right down here and is not very predictive, but you're in a sort of anticipatory state that pain might happen. This story of S2 and posterior insula is again a potential biomarker for you legally on the N of 1 to tell you that somebody still has got those pain fibres sending in signals and sending in nociceptive inputs to the central nervous system. Is being indirectly confirmed by looking at studies where there is no nociceptive input, but the people experience pain. There's been a couple of studies. Some are relevant, some are not so relevant. The slightly non-relevant ones, the empathy study, beautiful as it is, so I like to show it, and that's where you show somebody their partner being burnt and you look at their brain inactive. They took women because they felt they'd be more empathic than men, and they burnt their boyfriends at the end of the scanner, and they imaged their women's brains, and what you see illustrated there is red. They're areas of, again, that signature I showed you, lots of the effective parts of the brain being active when the women saw their partners being burnt. And when the women then got burnt, you see areas in green. And you can see that in many places there is an overlap, but not in that S2 and that posterior insula. You had to have the nociceptive input coming in order for them to have it. When she experienced empathy, the women, they couldn't activate the sensory discriminatory parts of the brain. And that's been confirmed by hypnosis studies, another indirect way of, if you like, faking it and getting people to experience pain when there is no nociceptive input coming in, there is no tissue damage, but they have a pain experience or pain-like experience. What do they activate? Well, they overlap all that network, except for the posterior insula and S2. We've done a study where, this was for Hank, because we spoke about this several years ago, where we have people recall pain. We burn them, and then 20 seconds later, we say that we'd like you to recall that pain experience. We have different levels of burning that we're giving them, and you have to recall the different levels. Amazingly, you're really good at it, and you really actually quite experience the pain. You rate it as, not as high as the physical pain, but you certainly rate it as painful. You have a vividness of the experience. And staggeringly, you switch on all those brain networks. So again, going back and, as there are companies here in the USA, venture capital, reading out on an N of 1, somebody's in pain using the old pain matrix. It's just nonsense, basically, and it's just not helpful, because I think what it's doing is giving a very bad impression for the field before we're ready to truly offer an interpretation of these maps. So what this is a subtraction of brain activity when you are feeling pain minus imagining it. Everything subtracts out, apart from the good old posterior insula, because you have to have a nociceptive input coming up to drive that N1, as I would call it. So again, that's another indirect proof of that as an area. Okay, moving on, if I can just have a few more minutes, if that's all right, because I want to move on to the chronic pain side of things, which gets more complicated. Those are all acute pain studies, but at least gives you a flavour of how variable and malleable things are. As we transit to chronic pain, which leads to complicated behaviour, more complicated things happen in the central nervous system. So we've done a lot of work looking at this phenomenon called central sensitisation and developing, in effect, a biomarker for one of the main physiological changes that occur in the body that underpins chronic pain, and it underpins the transition to it, and it underpins the maintenance of it. If you remove central sensitisation, chronic pain reverses. So it's key. And a key area that is important for it is this part of the brainstem that communicates down in a facilitatory way and basically, in a top-down manner, turns the volume up. So it basically amplifies it through LTP-like mechanisms. It's really, really fundamental. We've done a host of work with drugs and other work developing the imaging biomarker for this phenomenon. And in effect, it's centred on the brainstem, and we have a very good understanding of that now. We've just now translated that over into patients and shown, again, this is relevant for, take your hip patient. As far as the surgeons are concerned, you've got 20 patients with arthritic hips. They're going in for hip surgery, and some of them at the end of the year are still complaining they're in pain. Are they because they don't want to go back to work, or are they still in pain? Was there something different about them that they became the 1 in 5, or are they just making it up because they don't want to get back to work? How would you ever know from the subjective report? Well, we in effect mirrored that study, took them pre-surgery, looked at patients who had classic, what we call central-like changes to their pain, neuropathic-like elements to the pain. They'd gone central, if you like. They already were showing signs that they were different, with the hypothesis that this area that we'd worked on to show was the biomarker for central sensitization would be active and increased in that group of patients compared to the other group. Sure enough, that was exactly what we showed in this study. And moreover, how active they activated this particular area of the brainstem correlated with how neuropathic their pain was. And guess what? Of course, they all had their new hips, and surprise, surprise, a year later, they're still in pain. Hasn't helped at all. So again, that's changed fundamentally the surgeons in Oxford in terms of when they're and how they're selecting their patients for surgery. Because there's no point. If they're coming in to have a new joint for the pain, and you've already gone central, which this would indicate, which you're not going to get from the subjective report, that surgery is going to do nothing for them, so there's no point doing it. And again, for you, it would help discriminate that behind the scenes of what the patient's doing, when it looked like the surgery was just as good as the other one, so why are they still whinging and in pain? It's because things have already gone wrong for them. Okay, I've run out of time. The drug companies is the other thing. I just want to finish on this one, and I'll skip the placebo stuff, but they can maybe come up in a question if I plant that idea now in your head. And that is that, of course, if you're going to be able to read out pain for clinical diagnosis, courts of law, you've got to be able to do it for drug discovery. The three go together. So if you can't do it for any of these, you can't do it for any of the others. And of course, the stakes are high here. You know, drugs for pain is one of always the key disease areas for the drug companies, because you'll make on one drug $1 billion a year profit. So we've simulated the scenario with Pfizer using patients, knowing very well that on a small cohort of patients, head-to-head on two drugs that are reasonably effective and a placebo, there's no way you'd be able to discriminate behaviourally or clinically one drug from the other, and certainly not even from placebo. But can imaging tell you which one's which? So we've only just finished the study a month ago. We've only just been unblinded, but I think it gives you the sense of how powerful imaging can be, both in terms of the sensitivity of it, but also how it can tell you about the mechanisms of what's going on, and is so much more valuable than some of these behavioural measures ahead of time. So, for those out there, this is the group, this is their rating of dynamic mechanical allodynia. So if I stroke their arms, it's a burning pain there, so clothes and bedclothes are very unpleasant for these patients. And these are the three groups: placebo, pregabalin, tramadol. No significant difference. N of 16 patients. So very challenging study to do with imaging. And again, if you look at their daily pain, couldn't distinguish one drug from the other. We're imaging their brain activity in response to that brushstroke, which really, really hurts, and we're looking at their ongoing pain as well. And these are the three groups here. For you guys, you might just look and they look all the same, but again, understanding which are the key areas that we know encoding pain, like the anterior insula, these brainstem areas and other structures, we can quantify that. So in a blinded way, we then did the analyses and looked at key areas that we know, the anterior insula, and again, things like the brainstem, which I've spoken about in terms of its role for central sensitization, and we picked which one we thought was placebo, which one was pregabalin, and which one was tramadol. We were then unblinded, and there was a bottle of Lagavulin malt whiskey on this for me, and I'm happy to say I got it right, but I still haven't got my whiskey from Pfizer because of coercion problems, so I'm still hanging in there for that. But basically, this is quite a remarkable study. This is pretty landmark for them, because again, going back, they'd have found, not that they would have, but on an N of 16, you can't tell that this drug, pregabalin, that makes them $1 billion a year profit, doesn't look any better than placebo or tramadol. But with the imaging, on an N of 16, with all the dirtiness and the heterogeneity that is chronic pain patients, we can pick not only the drug from placebo, and again, behind the scenes, we can look at the more mechanisms of it, we can pick the two drugs from each other, and I think that's pretty powerful. So I've overrun, I'll stop there, but the other thing I was going to talk about was some of the recent work we've done on what we call the hidden placebo, and again, it's relevant for the biases that you might have against why is this patient not getting better on this medication, are they making it up? And it's just to show you the power of the mind and expectation can completely overrun one of the best analgesics we've ever found, and so therefore you can't underestimate for pain, the relevance of the brain, and particularly in a chronic pain patient, how long-lived and hardwired negative experiences, nobody's worked out my pain, no drug has ever worked. That negative expectation overrules everything. And that means that you might say that really there's no reason they shouldn't be getting better and this drug really should be working. But what we've shown in others is the power of that to block, is a roadblock on everything centrally. And because pain is an emergent experience of the brain, you can't run away from the power of that. So I shall leave it there. Thank you very much.
We are out of time, but if there is an urgent question out there, I'm a generous chairman and we can entertain one. Is there a question?
Well, from the patient's point of view, isn't the subjective report more important than your?
But when the subjective report's not believed, that's the problem. And that's been the problem, certainly for chronic pain. I think we have to be very clear between acute pain and chronic pain. So for the chronic pain sufferer, generally, they're not believed, they're perceived by both their local physician, and certainly if it got to a more difficult situation of disability fraud, that they're just making it up. And so I think as I say, the major contribution imaging's done, apart from understanding the mechanisms of these transitions, has been to show Here, fibromyalgia, classic illustration. Again, another way you could look at it, not functionally, is to take structural measures. Until people started to do these studies and said, let's look at just how many opioid receptors these people have in their brains and how well is their dopamine system working, and showing that they are dramatically affected compared to the age and sex-matched controls. Nobody believes there's anything wrong with these people. They're just making it up. They're neurotic. So for the patient, this has been hugely valuable. And I have literally on the website downloadable PDFs and files that are used in clinics and patients are used to validate, if you like, that the brain is where pain is, because a lot of patients don't like that. But when they realise that the brain is where pain is generated, and actually they have quite a lot of control over it, and that actually it can show that there is something wrong with them, that's very, very reinforcing for them. And again, it makes the local GP treat them a little bit differently and start to take the condition more seriously. So it's in fact, it's completely opposite to what you say. You're never going to go away from the subjective report. That's really critical. But having that objective proof that there's something not right with me, and I've not just been going on about this, has been really powerful for them.
Thank you very much.